That's compound injuries. So here's a patient who came with a compound injury to a hospital, and this was a well-equipped hospital. So the surgeon decided that he's going to use all the equipment he has, and he did. So he has wires, screws and plates, and external fixators. And yet the hand doesn't look very happy, does it? So all modalities are useless unless you use them correctly. And look at the hand. This is what was done. The debridement was forgotten. Your fixation is taking you nowhere. So be very, very aware of what you're doing for the patient. This is what I changed it to eventually after debridement when he came to me, and I put him in a fixator and got out all of those, left in some of the screws, allowed the bones to heal, and there's just a little bit of passive movement, and that doesn't look very nice. So be careful, because in an identical situation, this is a patient who came to us and has 9 fractures in a crushed hand, with 7 of them around the key MP joints. If you look at these fractures around the MP joints, you'll realize that the MP joints are going to be stiff, and you can see there's a middle phalangeal fracture, there's a proximal phalangeal fracture in 3-4 fingers. So each fracture was dealt with in the ways that we discussed earlier, and the hand was kept in a functional position using an external fixator. Only 2 pins in the metacarpals from the sides, and a full frame to hold the hand in exactly the functional position that we want. And what was the outcome? Absolutely different. So there's such a big difference. Obviously, they're not the same situation, but they're identical situations. But just using the principles, you can get excellent results. But not always can you do that. Here's a crush injury which is devascularized. So you're rushing to try and fix everything so that you can put back the blood supply and convert it from a bad to a clean wound and treat it as a clean wound. And this is what I did. So all what I said in the earlier lectures, in the earlier part of this talk, I have transgressed and done something different. I've gone retrograde wires, but these were quick, effective, and stable to try and restore blood supply. So you can change. Now, if I sat to plate all of this, that would take me 4 hours or 3 hours to plate 5 bones. That's not fair. This took 10 minutes, and here's the patient's outcome. Not so great. We did some extensor tendon work, and there he is. Absolutely wonderful. So sometimes you need to compromise what you know and what the principles are, because in the in the situation that it demands, you need to then be worried about time, and the fastest and the simplest technique is best for it. Here's an 8-month-old injury to a cricketer, and here we're now going to talk about the role of plates in these bones. That's again one of the questions that came out. And that slide should have been a little later. This is what we were talking about before the talk started. But the role of external fixators is in pediatric cases where you don't want to transgress the epiphysis. So in some of these cases, I would tend to use external fixators even today. But just putting an external fixator doesn't mean that the hand is going to do well. Reduction is absolutely essential. Debridement is essential. This got infected so badly that the patient came to me with an infected, non-salvageable finger. So we took out the finger and we moved the index finger towards the middle. The whole ray was shifted to the middle ray, and I used an external fixator in a very useful way here. So the external fixator initially was bad, but then eventually you can barely make out which finger came out, and you can see his function. Absolutely wonderful. So external fixators have a role, but a very limited role. Improper application is very bad, and distraction is not panacea. You can't use distraction for ligamentotaxis and say it will become all right. If the position is bad, it's not going to heal at all. What about the role of plates? Well, I reserve it for situations that I cannot handle in the manner that we've already discussed. I use it as an adjunct in many tricky situations, as we saw in the PIP joint. I use it definitely during reconstructive surgery, malunions, non-unions, and replants. Here's that same patient, the 8-month-old contracted cricket player who had an injury, and after 8 months, this is how the patient came to me. Just couldn't hold the ball and he's out of the game. and it's almost the IPL time. So I went in, got his X-rays and CT scans, went in, did an osteotomy, got the bone back into place and used a plate to hold it up there. And as opposed to the previous one where we saw the plate was recessed a little bit, I had to push the plate up. And you can see the effect of that. There is a little restriction of movement, but he's now able to play again. He was one of the reserves for one of the teams of the IPL this year. So he could get back his function. So that's where I'll use plates. Here's another one. Again, after 4 weeks, this is a patient that comes to me with a collapse. I open it out, get it into place, use a plate, and close the plate so that it's covered completely so that the sliding tissues do not come in contact directly with the plate. And there you can see his function. He's joined as a chef on the ship and he's back to almost near normal function. Don't use plates where you're not sure, or too flimsy plates which will not probably work. And this is a plate that broke. And in this case, what we did was we used what is known as piezo surgery, where we use ultrasonic micro vibrations to make the osteotomy. It's an absolutely wonderful technique. Doesn't generate heat. And you can get clean cuts, and you're able to then get bone grafts and fit them in and use a good plate to get union in this. Here's another one similar to that with an absolutely good function. So there are roles for plates, but be careful. Don't let enthusiasm get the better of you. Because if you jump in and put in too many plates, and if you're not careful of your technique, especially in compound injuries, you're going to end up with stiffness and infection. So you have to be very, very sure about where you're putting your plate, how you're putting your plate, how you cover the plate, and what size of plates you're using. Post-operative care, last 5 minutes of this session, 3 phases of recovery. And this we learned from Dr. B.B. Joshi, where he said the phase 1 is the dressing, phase 2 is the functional slab, and phase 3 is the functional cast. And then you splint and mobilize. So if you go through these phases, you're going to be able to get these patients to do very well. So in the dressings, no encircling dressings, always little gauze piece in between the fingers, and a bulky gamgee dressing to hold the functional position, keep the MP joints in flexion, keep the thumb out in opposition. To start to do that, what you need to do is to start rolling the bandage from the radial border of the hand onto the dorsum of the hand and then go around. When you come around that way, you'll be able to pull the thumb into opposition, as you can see, and gently draw it into opposition. So when you finish just with a gamgee and a crepe bandage, you can get the functional position of the hand. Absolutely wonderful. Once you've done this, you can apply traction and whatever else you need to. When you give a dorsal slab, always ridge the slab at the back. Now you ridge the slab, you make it with one single plaster roll, and you ridge it at the back so that it becomes stronger. Why do you ridge it? Let's see this. So that's a normal 1,000 rupee note, which is not available anymore, or is demonetized now. So I can deface it. And I made ridges on it. And now you can see that it can hold a full vial of LOX 2%. So why do you ridge the plaster? Because it makes it stronger. That's what you see in asbestos sheets and so many other principles, the I-beam technique, I-beam principle, etc. Basically, it's distributing the weight across those straight lines, and it makes it much, much stronger. And this is the functional cast. Nail traction, you should know how to give nail traction without causing any bleeding, without any pain, even in a patient who cuts or trims their nails very short. So you've got to learn this technique, and you've got to give counter pressure on the nail while you're pushing the suture through. You can use glue, but it's not as good as this. Axial traction is something that we don't use very much now because of the high profile splints that are involved. But what you need to use are splints that are much smaller, much more low profile, and will have their effect exactly where you want it. So if you do not know splinting in the hand, and if you do not have access to such wonderful splints, you cannot get results like what you've seen in this entire lecture. more than what happens within the operating room, it's what happens after that that gives you this kind of results. So you've got to learn splinting, you've got to understand when to use static splints, when to use dynamic splints, which way the dynamic splint is going to work, into flexion or into extension, which means is it a flexor assist or an extensor assist? How long do they wear it? How much do they wear it? This is all done, and you'll see this. You'll see this. Each one of us does this. Sorry, each one of us does this uh, personally, so that we don't leave this to anyone else. And if you have a good department of rehab, then probably they will take over, or an occupational therapist will take over and give you this. So finally, hand fractures. This has been for me 30 years a journey of understanding the functional importance of the hand, the understanding of the close relationship between stability and mobility, the understanding that no method is inferior or superior. They can only be successful if you understand the technique and if you use it perfectly well. The starting point for me is always the functional position of the hand. The end point, obviously, is the function of the hand. So finally, wisdom doesn't come in with the tide. This was a ship, Wisdom, that ran aground close to my house in Juhu Beach in 2011, and it looks like my wife pulled it in. But it doesn't come in with the tide. You've got to pilot it into your practice, and you need to anchor it there forever. Only then are you going to see your patients as happy as you want them to be. Thank you very much for your attention.